Lucena, and today I'm going to do the skill of nasogastric insertion of nasogastric tubing. So first, assess the history of nasal surgery or deviated septum. Check the patient's patency of nares. Determine presence of gag reflex. Assess mental status or ability to cooperate with procedure. Next is planning. Before inserting nasogastric tube, determine the size of the tube inserted and whether or not the tube to be attached to suction. And equipment, large or small bore tube. And non-allergenic adhesive tape. And then clean gloves, water-soluble lubricant, and then facial tissues, glass of water and drinking straw, 20 to 50 milliliter syringe. Then a basin, pH test strip or meter, stethoscope, clamp or plug, it is optional. Then suction apparatus if required, then safety pin and band. Then for implementation, assist the client to a high Fowler's position if his or her health condition permits, and support the head on pillow. It is often easier to swallow in this position, and gravity helps the passage of the tube. The mouth is hyperextend version. And then place a towel or disposable pad across the chest of the patient. So next is introduce yourself and verify patient's identity, and then explain to the client what you plan to do and why it is necessary and how the patients can cooperate. The passage of gastric tube is not painful, but it is unpleasant because the gag reflex is activated during insertion. Establish a method for the client to indicate, and then client to indicate distress and desire for you to pause the insertion, and then raising a finger or hand is often used for this. Wash hands and observe other appropriate infection control procedure, and then provide for client privacy by drawing the curtain or closing the door, and then assess the client's nares. Ask the client to hyperextend the head and using a flashlight. Observe the intactness of the tissues of the nostril, including any irritation or abscession. So, ma'am, can you please hyperextend? And then examine the nares for any obstruction, or determine by asking the client to breathe through one nostril while occluding the other and the other. Okay, and then select the nostril that has the greater airflow, and then prepare for tube. If a rubber tube is being used, place it on a ice for 5 to 10 minutes. He stiffens the tube, facilitating insertion. If a plastic tube is more flexible, the facilitates insertion. If small bore tube is being used, insert stylet or guide wire into the tube, making sure that it is secured in position. An improperly positioned stylet or guide wire can traumatize the nasopharynx, esophagus, and stomach. Determine how far to insert the tube. Use the tube to mark the distance from the tip of the client's nose to the tip of the earlobe, and then from the tip of the xiphoid. And then use the tube to mark off the this length approximates the distance varies among the individual. Mark the length with adhesive tape if the dose net tube has markings. And then put on gloves. And then lubricate the tip of the tube well with water soluble lubricant or water to ease insertion. A water soluble lubricant dissolves if the tube accidentally enters the lungs. An oil-based lubricant such as petroleum jelly will not dissolve and could cause respiratory complications if it enters the lungs. Insert the tube when its natural curve toward the client's into the selected nostril as the client to hyperextend the neck and gently advance the tube toward the nasopharynx. And then direct the tube along the floor of the nostril and toward the ear on that side. Directing the tube along the floors, avoid the projections along the lateral wall. Slight pressure is sometimes required to pass the tube into the nasopharynx, and some clients' eye may water at this point. Tears are naturally body response. Provide the client with tissue as needed. And then if the tubes meet resistance, withdraw it, relubricate it, and insert it if the other nostril. The tube should never be forced against resistance because the danger of injury. Once the tube reaches the oropharynx or throat, the client will feel the tube in the throat and may gag and retch. Ask the client to tilt the head forward and encourage the client to drink and swallow. Tilting the head forward facilitates passage of the tube into the posterior pharynx and esophagus rather than into the larynx. Swallowing moves the epiglottis over the opening to the larynx. Mom, can you please tilt forward? If the client gags, stop passing the tube momentarily. Have the client rest, take a few breaths, and take sips of water to calm the gag reflex. In cooperation with the clients, the tube 5 to 10 cm with each swallow until the indicated length is inserted. If the client continues to gag and the tube does not advance with each swallow, withdraw it slightly and inspect the throat. By looking through the mouth, the tube may be coiled in the throat. If so, withdraw it until it's straight and try again to insert it. And then Aspirate stomach contents and check the pH, which should be acidic. And research indicates that testing pH is a reliable way to determine location of a feeding tube. And then refer X-ray as per agency policy. If a small bore tube used, leave the stylet or guide wire in place until correct positioning is verified. X-ray. And then auscultate air insufflations by placing a stethoscope over the client's epigastrium and injecting 10 to 30 ml of air into the tube while listening for whooshing sound. Do not use this method as the primary method for determining placement of the feeding tube because it is often unreliable. If the signs do not indicate placement in the stomach, advance the tube 5 cm and repeat the test. If a small bore tube used, leave the stylet or guide wire in placement. Correct position is verified. Secure the tube by taping it to the bridge of the client's nose. If the clients have oily skin, wipe the nose first with alcohol. And then cut 7 to 5 centimeter tape and split it lengthwise at 1 and leaving a 2.5 centimeter tub in the end. Place the tape over the bridge of the client's nose and brings the split ends either under the tubing and back up over the nose. And then attach the tube to a suction source or feeding apparatus as ordered or clamp the end of the tubing. The tube, if inserted preoperatively, is usually clamped or plugged, or it may be covered with gauge square or plastic specimen bag and an elastic band. Secure the tube to the client's gown. Then loop an elastic band around the end of the tubing and attach the elastic band to the gown with safety pin or attach a piece of adhesively taped to the tube and pin the tape to the gown. The tube is attached to prevent it from dangling and pulling. And then document relevant information, the insertion of the tube, the means by which correct placement was determined, and client responses if there is discomfort or abdominal distension. And then establish a plan for providing daily nasogastric tube care. Inspect the nostril for discharge and irritations. Clean the nostril and tube with moistened cotton tip applicator. And then apply water-soluble lubricant to the nostril if it appears dry or encrusted. Next is change the adhesive tape as required. Give frequently mouth care. The client may breathe through the mouth and cannot drink. If suction is applied, ensure that the patency of both the nasogastric and suction tubes is maintained. Irrigations of the tube with 30 ml of normal saline may be required at regular intervals. In some agencies, irrigations must be ordered by the physician. Keep accurate records of the client's fluid intake and output and record the fluid intake, output, and record the amount and characteristics of the drainage. And lastly, document the type of tube inserted, date and time of tube insertion, type of suction use, color, and amount of gastric contents, and the client's tolerance of the procedure. That's all. Thank you.